Hello everyone, welcome to the latest webinar from our Queen Elizabeth Scholarship Program in Strengthening Health Systems, brought to you by the McMaster Health Forum at McMaster University in Hamilton, Ontario, Canada. For today's webinar, I'll provide you with a little bit of information on the McMaster Health Forum, the Queen Elizabeth Scholarship Program, and the current version of the scholarship here at the Forum. I'll then turn things over to our incoming scholar presenter, who's Kelsey, who's visiting us from Australia. Her presentation is on low-value healthcare, an Australian perspective. Here at the McMaster Health Forum, we aim to be the leading hub for improving health outcomes through collective problem solving. We harness information, convene stakeholders, and prepare action-oriented leaders. We act as an agent of change by empowering stakeholders. The current Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose of the scholarship program is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The current version of the Queen Elizabeth Scholarship Program that's offered here at the McMaster Health Forum is called Strengthening Health Systems. Our scholars will contribute to strengthening health systems and become part of our large and growing network of health system leaders. The Forum's current QES program has had 3 cohorts of students. The first cohort, as you can see on the screen here, comprised students who mainly went away or visited us in the calendar year of 2016. Our second cohort of scholars, which comprised 22 students, primarily engaged in their scholarship in the calendar year of 2017. The third and final cohort of the current version of the Queen Elizabeth Scholarship Program here at the McMaster Health Forum primarily went away or visited us in the calendar year of 2018. Today's presenter comes from the large group of incoming scholars who worked with us in the spring and summer of 2018. Today's incoming scholar presenter is Kelsey, who's visiting us from Australia. She is a PhD candidate at the University of Sydney in the Value and Healthcare Division. Her research investigates the use of low-value healthcare delivered within Australia's public and private hospitals. Kelsey is aiming to build her skills on using evidence and understanding the political influences on health policy. Kelsey, I'm going to turn it over to you.
All right, good morning everyone. My name is Kelsey Chalmers. I'm a PhD student from the University of Sydney's Menzies Centre for Health Policy. So for the past 3 weeks I've been visiting the McMaster Health Forum thanks to the Queen Elizabeth Scholars Program. And here I've had the opportunity to study evidence in health policy, setting agendas in health policy, as well as the different components of health systems. So in this presentation, I'll be discussing my PhD topic of low-value healthcare, and I'll also use the concepts I've learnt here to discuss some of the Australian healthcare policy decisions on addressing low-value healthcare. So what is low-value healthcare? So let's start off by discussing what value is. The value of a healthcare service is just a function of its expected benefits relative to its expected cost. So services with a high expected benefit or improved outcome with low delivery cost or small risk to patients will be of high value. Those services that provide little to no improved outcomes relative to their cost or harms are considered low value, particularly in cases where there's alternative higher value treatments available for patients. Put simply, we can judge the expected outcomes for individual patients based on evidence for similar groups of patients. So some services are clearly effective for particular patients, so clearly high value services, while others are clearly ineffective or provide no value, while others may be more uncertain or in this grey zone. Healthcare funders and healthcare providers have to decide the point where these grey zone services can be considered low value, the type of patients they are low value for, and how best to avoid these treatments for these patients. So low value care can exist in a healthcare system for a number of reasons. So healthcare services will fall out of fashion for one of 2 reasons. they're either replaced by a hopefully higher value service, or new evidence arises which shows their low value, and then we can begin to disinvest resources from delivering this service. However, this disinvestment can be slow relative to investment in new healthcare technology for several reasons. And the first point is on the evidence that we expect for our healthcare services. So one issue is that research is more likely to be funded by private industry and governments if it is investigating new technologies rather than the efficacy of current commonly used services. Another issue is that published research on new healthcare technologies generally tend to show more positive results compared to research on currently used technologies, which might be a result of a publication bias. And despite the push and popularity on evidence-based healthcare, many services, and particularly surgical interventions, haven't been compared to a control treatment in any randomized control trial. And at least in Australia, it's been suggested, and we'll see this soon, that the evidence barrier for approval and funding of new technology is lower than the quality of evidence that's required for funding or access to be changed for a service. Part of this is due to the cognitive biases that exist in delivering healthcare. One is the demand for healthcare or interventions from patients or healthcare providers. Sometimes the best treatment might be to watch and wait rather than to intervene with a healthcare service. We're also susceptible to a confirmation bias where only evidence that confirms our current beliefs are accepted. Another issue is dealing with sunken cost bias, where it's difficult to disinvest from healthcare services where we spend a lot of time training and investing resources into delivering that healthcare. Often low-value care arises because of an indication creep as well for approved services, where we assume without any evidence that a service is going to be beneficial for one group of patients because it's beneficial in a different group. Other identified drivers of low-value care can include financial arrangements such as fee-for-service, where healthcare providers are rewarded for the volume of services they provide rather than the outcomes of these services, as well as delivery system arrangements such as unnecessarily providing services in high-cost settings. So these are some of the factors, and there's many others that can lead to slow disinvestment from low-value healthcare. So I'm going to talk through one example, which is vertebroplasty. So this is an intervention which is provided to patients with incredibly painful osteoporotic vertebral body compression fractures, where, again put simply, a concrete mixture is injected into the spine of these patients. So in the mid-1990s, a pair of US surgeons developed the procedure and conducted it on 29 patients in this study. 26 of these patients self-reported that their pain decreased after the procedure. And based on this, it received funding in the US, and by the year 2000, also in Australia. In 2002, a US researcher conducted a pilot study of a randomized control trial using a sham procedure, essentially where the injection occurred was provided to these patients, but there wasn't any concrete mixture mixed in. He then switched these patients a few weeks later, and all patients in either group reported the same decrease in pain no matter what treatment they received. Meanwhile, by 2005, there were 27,000 of these procedures occurring in the US every year. Funding and recruitment for a randomized trial of the vertebroplasty was delayed due to issues around patient recruitment, since providers and patients were really hesitant about receiving a sham procedure, as well as getting funding for the trial. So, however, eventually in 2009, the results from the US study, as well as an Australian-based study, were published in the New England Journal of Medicine and demonstrated that there's no difference in the self-reported pain or functional status between the control groups or the treatment groups, despite this being such a commonly used procedure for the past decade. So that brings us to the Australian setting. So I'll first just introduce our Medicare benefit schedule. So Australia has a national insurance scheme, Medicare, which is run by the Australian federal government. Medicare funds care provided in public hospitals, which is free at the point of care for patients. For most healthcare provided outside of those public hospitals, Medicare provides a rebate to patients for healthcare services, including those that occur in a private hospital and are additionally funded by private health insurance. The Medicare benefit schedule lists the descriptions of these services as well as the rebates that will be provided to patients. So after vertebroplasty was found to be low value and essentially removed from the schedule in 2012, governments and researchers started to question what other services could potentially be low value. The issue was raised that while the MBS had such a formalised approach for adding new services to the schedule, the process to remove these services was less clear, and that many of the 5,700 services listed on the MBS had not been examined or updated with any new evidence as it was published. The study here, published in 2012, systematically did that, and they identified 156 MBS items that were potentially low value based on new results from randomized control trials. Similarly, the Australian Commission on Healthcare Quality and Safety also started publishing an atlas of healthcare variation, investigating the amount of services used per population within different Australian regions. And like many atlases around the world that are published, we see that there's high variation in use between different services in Australian regions. So geographic variation can imply an underuse of appropriate healthcare in some regions, but it also potentially means that there's an overuse of low-value healthcare. So with this evidence in mind, the government decided to introduce, for a number of reasons, the MBS Review Taskforce. So basically the task force is made up of a group of clinicians and expert academics who govern a set of clinical committees who are commissioned to investigate practically as many MBS items as possible, and whether they can change the descriptions of the MBS items to be more value-based and evidence-based. So part of the reason why they decided on this policy was that the federal government had a lot of previous backlash to cost-saving policies that they'd tried to introduce in healthcare. Whereas with the MBS Review Taskforce, they could position it as a clinician-led as well as an evidence-based review. And that this wasn't a cost-saving measure, it was introducing value into the system. And if it happened to save money, then that was great for everyone. And any backlash or arguments about the evidence that was used in the review could be targeted against the task force and not the government. Part of the politics at the time when the MBS review was announced, there was a big media investigation on one of our public broadcasters, ABC. The Four Corners program investigated waste in healthcare and basically put forward this problem to the Australian public and discussed issues around vertebroplasty, spinal fusion, knee arthroscopy, and overuse of imaging services in the Australian system. And they estimated that $46 billion were wasted. It was a rough estimate, but I had the pleasure as part of my first year of my PhD in helping get that estimate in. So that was my first introduction into the political process in decision making. And so finally, just an update on the MBS task force. The task force has delivered a number of recommendations to date in Australia, and the Federal Health Minister has started acting on these decisions. It's also received ongoing funding to continue its work, as well as to set up a proper process to remove MBS items from the MBS schedule. And finally, as the government states here, we'll hope to have a better MBS for all Australians. So I've had a fantastic time in Canada with my fellow QES scholars and have learnt a lot in 3 weeks in the workshops that have been delivered here. So I'd just like to extend a very enormous thank you to the McMaster Health Forum, as well as the Queen Elizabeth Scholarship Program, the Queen Elizabeth Scholars here as well as to everyone back home, my supervisors, the Menzies Centre and the Capital Market CRC for letting me leave for a few weeks to have this experience. Thank you.
For those of you who are able to make it here today to watch the presentation in person, I want to thank you for coming out. For those of you that have watched the video later on YouTube, thank you very much for taking the time. Before we leave you today, I just want to take a minute to go over a couple of the links that are on the screen to provide you with additional information about our program and what our scholars have been doing. If you're interested in the Forum's Queen Elizabeth Scholarship Program, either the current program, which is ending in 2018, or the new program, which is actually being launched in mid to late 2018, I would encourage you to please click that first link. That will take you to the information page at the McMaster Health Forum's website and tell you all the information you need to know about our Queen Elizabeth Scholarship Program in terms of how to apply and how to be involved. If you're interested in other presentations and webinars by our Queen Elizabeth Scholars, I would encourage you to click on that second link. There you'll find all of the current webinars that have been done by all of our Queen Elizabeth Scholars, and future webinars that our scholars will be doing will also be posted there. And thirdly, you'll see that there is a link for our scholars blog page, which is machhealthforumscholars.com. Our scholars write blogs about personal reflections about their experiences while abroad or when they visited Canada if they were an international scholar. So please visit that page and read some of the blogs that our scholars have posted. Feel free to follow us on Twitter at MacHealthForum, and please follow the hashtag QEScholars so you can see all of the fun and exciting things that scholars have been doing from multiple universities around Canada. Thank you for joining us, and we'll hope to see you again soon.